Welcome to TCN Talks. The goal of our podcast is to provide concise and relevant information for busy hospice and palliative care leaders and staff. We understand your busy schedules and believe that brevity signals respect. And now, here's our host, Chris Como.
Hello and welcome to TCN Talks. I'm excited about today's show. Our guest today is Carla Davis. She's the Senior Vice President of Hospice and Palliative Care Operations and Business Development for LHC Group. Welcome, Carla.
Thanks, Chris. I'm looking forward to it.
I'm looking forward to it as well. I've been a fan for a long time. I've been stalking you, but I've been a fan. I just remember the first time I heard Andrew Reed talk about you, and I'm like, I want to meet this Carla. And I've said for years, I think you're probably one of the two smartest people in our industry. I met you at the NHPCO conference many years ago. It was at Wild Horse Pass. It was the one that Jim Collins was at, and made such a great impression on me. You lived up to all the expectations. Feels like our paths have been crossing in interesting ways. I remember hearing the story about when Dave Ream and Carolyn Kaysen discovered you. Maybe you might weave that story in.
Out of proportion, I think, over the years. The funny story about Andrew Reed is my first job out of college was working at Medicare. And on the desk were a stack of the Medicare regulations, right? But on top of the Medicare regulations was a note from my predecessor. And she said, if you have any questions, call Andrew Reed.
Oh, that's too cool.
Yeah. So we go way back.
Yeah. And you, of course, ended up taking over a hospice where I was a coach for a while, fell in love with the wonderful people based out of Lafayette, Louisiana. Heart of Hospice there, and I know you did a phenomenal job with them. So again, I feel like our paths have crossed in multiple ways, but we've never really spent much time together. So I'm super excited about today. So let's just start with first, what does our audience need to know about you?
Well, I have been in hospice all of my life. So I went to Davidson College in North Carolina, right down the street from you. And this was around 1990 when Bill Clinton was running for president. And I was in this class on rationing medical care. And I learned at that time that we were spending about a third of our Medicare dollars in the last year of life, and most of that in the last few months of life. And I think this is kind of relevant to this conversation because that's where I started. And I didn't know that hospice existed, but I knew people were dying these miserable deaths behind curtains in hospitals. And so I decided I'd write my paper for that class on end-of-life care and basically how this could be the solution to this impending healthcare crisis that we had. And I remember typing into the card catalog thing because the Google, as my mom calls it, did not exist at the time. And you typed in things and then out popped on the printer with the holes on the side, the paper, all the articles and books and things about end-of-life care and healthcare cost. And of course, all of them were about hospice. This is even in 1990. And so I took all of these things home and for Thanksgiving break, and I learned about hospice. And I can tell you where I was sitting. I feel like I had a calling at that point to help people at the end of their life. I knew that this was part of our solution to our healthcare crisis, but it was also just the right thing for people. So that's when I was 19. I ended up creating my own major in medical ethics and focused specifically on how the American healthcare system should change to better integrate the hospice philosophy, which is sort of nerdy when you're 19 and 20, to focus on end-of-life care at that time. But I just knew. And never in a million years would I have guessed that God would have had me on the path that I have been on. But I feel really blessed to be where I am now and helping to lead LHC's hospice and palliative care and help more people, because that's what it's all about.
Wow, that's awesome. And I learned some stuff I didn't know there, Carla. I didn't know about the Davidson connection. That's actually really cool.
Yeah, we did more than Steph Curry.
Well, so talk a little bit more about the seat that you're in now. You're now part of one of the few vertically integrated health systems and really the largest one in America. So maybe what are some of the positives and maybe some of the challenges?
Yeah, well, just to orient the audience a little bit, LHC has been a part of and building really a vertically integrated care continuum in the home for 25 years, starting in 1994 with home health and 1998 with hospice, home and community-based services and other services sort of complementary. But in March of this year, we were purchased by Optum Health Services. And so just at this point, we're just in the beginning stages of trying to integrate in. I mean, I'm excited about it because we are in a position to be able to create really the most comprehensive suite of services to wrap around the beneficiaries that are aging in our country, and to help shepherd them through whatever needs they have as they wax and as they wane, and especially people that are living with serious illness. It's exciting to me to be a part of a payer organization because I think that will allow us to innovate and to change and figure out what the care delivery model needs to look like, and not just improve the quality, but also, come up with solutions to knock down barriers to people getting the right care at the end of life. And I don't know that it's going to look like it does today. And I, quite frankly, hope that it doesn't. But to kind of get to the challenges, I think, and just even in my career, I started after Medicare, I worked for what is now Kindred, or Gentiva, or whatever the name is now. But at that time, it was nursing homes and LTACs and also home health and hospice. And I've also worked for HCR Manicare, which of course is a large post-acute healthcare continuum. And just because you are in a vertically integrated continuum doesn't make it function that way, right? And I think today in America, unfortunately, reimbursement tends to drive us to be relatively siloed. And I think that's what we're all trying to solve for. I mean, we all want the patient to get the right care at the right time, but the structure of the way that we're reimbursed, it isn't all the incentives aren't aligned. So that's why I'm honestly thrilled about this Optum purchasing us, because I think that we are in a place that we can really figure out what it needs to look like to transform end-of-life care. And I'm not naive enough to think that it's not going to be a lot of work and we're going to mess up and we're going to have to figure some things out, because to really change end-of-life care, we have to change ourselves. And so what that looks like, I don't know, but I'm excited to be a part of helping figure it out.
No, I'm excited for you to be in that role as well. I've said for years, I've watched LHC Group, because I don't know if you know this. So I grew up in Opelousas, Louisiana, which was the...
Oh my gosh, I did.
Yeah, so you know the connection then, because that's where Keith started. Really, LHC Group is really that, think it was that doctor's hospital, home health program, something like that. So a lot of interesting kind of connections to that. So I've said for years, gosh, if they get an incredible leader, it'd be really interesting to see what someone does with that platform. So I think you found yourself in an amazing position to shape what the future looks like.
Thank you to our TCN Talks sponsor, Delta Care RX. Delta Care RX is also the title sponsor for our May and November 2023 Leadership Immersion courses. Delta Care RX is primarily known as a national hospice, PBM, and prescription mail order company. Delta Care RX is a premier vendor of TCN and provides not only pharmaceutical care, but also niche software innovations that save their customers time, stress, and money. Thank you, Delta Care RX, for all the great work you do in end-of-life and serious illness care.
Yeah, I'm very excited.
Well, let's talk about some really good common ground, which is the NORC study. And you're on the board for NHPCO, is that right, Carla?
I am.
So so that study has been huge. I'm a huge Don Taylor fan. You probably remember before the NORC study, that's the last thing that we've really had to say data. We know hospice saves money because of this wonderful study. So talk to me about the study. What have you kind of taken away from it? Have you utilized it? Anything along those lines?
Well, I think it's one of the most comprehensive studies looking at the claims data for all of the Medicare decedents in 2019. So I think it is one of the most comprehensive studies. And it shows what I think we all know, is that the problem isn't that people are getting too much care too early. They're getting referred to hospice too early. It's that they're getting referred too late or not at all. And it proved certainly cost savings, 3.1%, which was about $3.5 billion compared to people that were end of life that did not access the hospice benefit. I really think those estimates are incredibly low, because what it also proved, two sides of the coin that I think were maybe surprising to some people, although I think not most of us that have been in this work for a long time. And the first side is that the patients that actually cost Medicare more money than anything are the patients that are in the last 2 weeks of life, really the last 10 days of life. In fact, the line is really between day 10 and day 11. And yet 25% of the people we see die in 5 days or less. So we have, those patients deserve care. They deserve, of course, we're going to serve them, even though we are referred an actively dying patient. And we're going to move with expediency to help take care of them. But they are expensive to hospices. They are expensive to the system. That patient, if that patient had gotten access to care earlier, they would have had a better experience. They would have been with the people that they love, comfortable, not in the ICU, spending all of these resources. But we also would have saved Medicare money. So I think, the front side of things, the only patients that were proven to actually cost the system more were the patients that live less than a couple of weeks and really less than 11 days. And on the flip side of that, what I think was really interesting is that even for the patients who live greater than 6 months, regardless of diagnostic category, which I think shocked a lot of people, including, neurology, respiratory, and all of them, those patients also saved Medicare money. In fact, 11%. So I think that the position that MedPAC has taken historically over the last few years, and concerns about patients living too long and abuse in the system, and we'll kind of get into this in the next article as well, but really the problem is get more people care that are facing end of life and get it to them earlier. And we know that. We know that when we talk to patients and families, they are so relieved to actually have someone coordinating this discombobulated healthcare system that we live in, and to have everything centered around them, to be patient-centered, to really be patient-centered, and to have all of the support and resources that hospice provides in the comfort of their home. But they're almost angry sometimes when they wish they'd known about it sooner. Why did someone not let us know sooner? So I think I think it proved what we know, but it is definitely the most current and most comprehensive research based off the claims data. So in terms of how we should use it, and how I'm using it right now within our organization, so just I think, first of all, it has incredible policy implications with Congress, certainly with MedPAC too, and anybody who's in a position to influence policy and influence the future of our reimbursement rates. Certainly, this is in the context of MedPAC recommending over a period of years a significant reduction in our reimbursement rate. At the same time that we all experienced all of the inflation through COVID, where not only are nurses more expensive and social workers more expensive and physicians more expensive, but mileage is more expensive, DME is more expensive, all of the things. So I think it puts that declaration that MedPAC and others have been concerned about, it puts it in perspective. We're focused on the wrong thing here. We need to focus together on how to get more people this care, not how to, to cut the hospices and basically incent them to serve less people. So I think it's a really, really powerful statement. We're also using it organizationally in our communities. We've developed educational tools using all of the materials from the study that NOC and NHPCO sponsored. Both of them co-sponsored it, which I think also is a great step forward for the industry to work together on this kind of thing. And we're using it to educate people in our communities, whether those are more regional health plans, whether those are ACOs, certainly health systems. And I think physicians care about this too. Periodically you'll hear physicians talk about they read something somewhere about the expense of hospice. And I think this is really, really helpful for them to understand that, in fact, the opposite. So we do follow up on all referrals with our referral sources, including physicians. And if that referral source or if that physician referred a patient that either died before we were able to get them care, despite how fast we moved, or died within the first month, we try to follow up very specifically to help provide education about how together we could have identified this patient earlier. And I think this study, and again, we're just starting to use it now, but I think this study will be a helpful part of that conversation.
That's great, Carla. Well, Carla, there's another study, and actually I want to give Craig Jeffries with Compass's credit. He's the one who brought it to my attention. The abbreviation is the NEBR study, the NBER study, and Jonathan Gruber is one of the main authors on that paper. I don't think it's kind of hit like national press yet, so it's not in everybody's hands. I'm trying to see what NEBR stands for.
National Bureau of Economic Research.
There you go. So if you had a chance to take a look at it, and what were your impressions from it?
I did. I did not read all 75 pages.
Me neither, in all honesty.
In all honesty. So just for the audience who may not be as familiar with it, it was focused on patients with Alzheimer's disease and related dementia, with the hypothesis that those patients are more profitable. And with the rise of for-profits over the last 15, 20 years in America, that they're incented to serve these patients disproportionately, and that's potentially bad for the Medicare system. And in fact, what it proved was opposite, that even these patients who tend to have maybe a longer length of stay and therefore may be more profitable, even these patients save Medicare money. And it really is both primarily cost avoidance, like nursing facilities, home health, pharmaceuticals, of course, hospitalizations. And so the article goes on, and I think it probably didn't get as much traction because it wasn't peer reviewed in terms of that category. But it even goes on to really kind of assert that policy issues that are going after the potentially longer length of stay patients, like Medicare caps or any kind of anti-fraud lawsuits or those kinds of things, those have an inadvertent impact, or could have an inadvertent impact, on restricting access. And even if a patient lives longer than 6 months with Alzheimer's, that they still save the system money. So I looked at the 2020 data, which of course is the last data, and of course is a little bit skewed because of what we were all dealing with in 2020. But the average length of stay, even for that Alzheimer's category of patients, was 143 days. And the median length of stay was 56 days. So, certainly where there's a few patients that live longer, definitely. But even with it, it saves Medicare money. And when hospice behavior, because of all of the either the cap or government regulation, targeting the nickel rates or whatever it is, when that behavior starts to create a pendulum swing such that we start to restrict access because we're so fearful to take a risk on a patient who looks like they're dying but may not be checking all of the boxes, it ends up actually costing the government money. So to me, to put these two important pieces of research together and for them to come out in the earlier part of 2023 together really does say something very strong. And we need to sort of shout it from the mountaintops to make sure that all of our regulators, including the MACs, understand it, because, they have the way that they've been doing things for a long time. And I think that because they laid off during COVID, they're definitely in full force now trying to catch up for all that downtime. But, we need to certainly get the message out. And I just want to say, to be clear, that doesn't mean that there aren't bad apples out there, and we don't need to do something about that. The National Hospice Organization and NORC have also been very vocal about recommending 34 different strategies to mitigate some of the fraud and abuse that has developed over the last few years. Again, some of that happening during COVID when maybe the survey processes weren't quite as tight as they were in years past or are now. And I think we have really an entry issue for the most part with the proliferation of hospices that opened in 2020, 2021, and 2022. And there are solutions, and not one of them is going to be a panacea to solving that section, but it is a very limited section. And I think what we have to be very careful about is that we don't have unintended consequences to providers who are doing the right thing and helping people live the last stage of their life and saving Medicare money. So if we need to be able to sort of incisively address the fraud, and there is some, but for the most of the hospices out there, they're trying to do the right thing, doing the right thing, delivering high quality care. And that's, I think, what both of these articles stated, regardless of the tax size.
Yeah. So when we do these, Carla, we're taping several podcasts. So I have Joan Tino later today. Her show will be aired. And so Joan, in the prep for the show, she said something profound. She said, all the fraudulent stuff, her back of the envelope calculation is about 7 to 8%. Let me be very clear. 7 to 8% of the providers. So you're and then of course that's what gets sensationalized in the press, etc. You said something a couple moments ago. Years ago, there's a physician that both you and I know said something that literally was like a brain tattoo. Said, wouldn't it be awesome if the distribution of our patients looked like a bell-shaped curve? But it doesn't, right? It actually looks like like a backwards J, depending upon the tail of longer length of stay patients. And I've always held on to that. I'm a bit of an idealist as part of my part of my issue, but I love that would be so ideal. And what do you think about that? Like when I'm hearing you talk about this study, I mean, could we use that to one day it really did look like a bell-shaped curve, or like maybe our median was 50 or 60, and the tail, you didn't have a lot of short length of stay and you didn't have a lot of long length of stay. What would it take for us to live in that kind of panacea, if you will?
I don't know that that's the answer. I think that's not how.
Okay.
I mean, I'm not saying that what he said wasn't correct. I mean, it is dreamy, right? But how do you drive behavior to be bell-shaped? And how when we all live and die of such variety of diseases, and there are so many things that impact prognosis that are not on an LCD worksheet. I think about my dad. My dad died 5 years ago, Father's Day, and he outlived every prognostication. There's no absolute reason he would be the tail, right? I mean, he was the tail. Of course, I'm his daughter, so I did advocate strongly for him to get hospice, of course, but there was no reason physically he was alive at the last bit of his life. But I know now, looking back on it, that they found his brother who was shot down over Laos in the Vietnam War, 50 years, almost to the month that he was shot down, and they found his remains. And my dad got told that. I got to tell him, and my dad got to go to the funeral. And there's no way he should have been there. He was bedbound in a nursing home, but he got to go and he got to say goodbye and hello to his brother. So there are so many things that are off the bell curve chart. I'm sorry for getting emotional.
No, that's awesome.
That don't fit, right? So how do I think it should be at this point in my thinking? I wish, honestly, and this is not going to happen tomorrow, but this is one of the things I'm excited about. I wish we could kind of get rid of the word hospice or the word palliative care and have these artificial lines of demarcation that are based off prognosis. Eventually I would like for it to be based off of need, and every person living with a serious illness could receive the care that they needed at that time. And perhaps there would need to be some kind of stratification or some kind of case mix that helped go up and down with patients as their needs went up and down. But it wasn't prognosis based. And I think ultimately that's the new bell curve. And I have a dream that happens at some point.
I'm so glad I asked you that. Thank you. And thanks for sharing that personal story. Because, as I think about some tools out there that retrospectively look at claims data and then say they're going to be predictive. I mean, I've grown up in this. You've grown up in this. We see stories like your dad's and the will of a human being, and then the care and love that hospice brings. That is so hard to build into an algorithm, and then see how that becomes predictive. And so, well, last question, Carla, and then we'll wrap up. And so, maybe are there some unanswered questions that you think maybe future studies need to kind of address that neither the NEBR or the NORC study that have kind of addressed?
Yeah, and I think to me it goes towards what I just said. Actually, so what would that need to look like if we took away everything that we know to define benefit structure right now, and we really looked at and studied what do people really need and want, and at what phase, and what would that cost? I think that something around more comprehensive care for the seriously ill, and trying to figure out what the reimbursement structure should look like. I think that's one thing to deal with what we have today, and to sort of move from 1.0 to 1.3 or something versus sort of 2.0 or 3.0 that I just described. I mean, I think we should start to test stuff more comprehensively than the MCCM, demonstration. So what would it cost if hospice went all full risk? And by that, I mean, really, no non-related, full risk. I mean, we are mostly all risk, especially the way that the government has, come back and reemphasized that we expect most everything to be related. But full risk. And what would it do to add concurrent treatment? What does that need to add to our PPD? Because of course the hospice benefit today does cover palliative treatments, but most hospices are not able to afford to do that, or to do that as thoroughly and extensively, both because of the advent of medicine and how advanced it's gotten and expensive it's gotten. But what would that look like? What would palliative concurrent care really cost if we were really to reimburse the hospice separately for that? I think those things could move the needle more towards your bell curve with the benefit structure that we have today.
That's awesome. Well, Carla, any final thoughts?
That's it.
Awesome. Well, you've been great. And Carla gave me a quote, so we always end our podcast for our listeners. It's a Marcus Aurelius quote. Had no idea she loved Marcus Aurelius. I love Marcus Aurelius. It's from his Meditations book 5.20 or 5.20. This is the quote. The mind adapts and converts to its own purposes. The obstacle to our acting, the impediment to action advances action. What stands in the way becomes the way. Thanks for listening to TCN Talks.